Okay, our next student presentation is Katelyn Ng, and here she comes on her way up to the stage.
Thank you guys for your patience, and thank you for that introduction earlier. My name is Katelyn, and I'm currently a second-year perfusion student at Midwestern University in Arizona. And today I'm going to be talking about how my program conducted a study on analyzing the biocompatibility of circuit coatings using biomarkers for platelet activation during cardiopulmonary bypass. So it's lots of big words, but just a really quick crash course on our research. So before I get started, this is just a general overview of everything I'm going to be covering today. This project has been in the works for several years, so I'm going to be focusing on how this experiment was created and conducted, and I'll also give a little sneak peek of our results. And this was also led by two of my professors, Dr. Darvin and Professor Rath, who is here today. So I just want to take a moment to say thank you to them and the rest of my team members for getting me to where I am today. I'm super excited to share our project with everyone at Sanibel. Now, in terms of the project, so just to set up the stage, when we put a patient on bypass, we're essentially introducing them to a foreign surface, the majority of that being the surface coating of our circuit. And some of the most common sources of blood material interactions during bypass include hemolysis, platelet rupture, and protein adhesion, which has been associated with the morbidity of bypass. But that being said, there has also been research discussing that material-independent blood reactivation can also play a role in said morbidity, which can include things such as blood exposure to air, like gaseous microemboli, also known as GMEs. Now, when platelets bind to foreign surfaces, inflammatory cytokines are then released and the intrinsic coagulation pathway is activated. And during this activation, surface markers of platelets, including PF4, GP2B3A, beta-TG, and soluble P-selectin are then released. Now, what's the significance of all of these being released, though? During cardiac procedures involving bypass, especially the ones with super long and complicated bypass runs, I'm sure a lot of us have actually experienced as well, can have an increased risk of abnormal bleeding after the case and other complications, including sears and sepsis, which could even lead to organ failure. Now, throughout the years, there has been a lot of modifications to try and mitigate these blood interactions and reactions. And perfusion is a relatively young field, but as we can see, especially from this conference, there's been a lot of advancements throughout the years, including creating biocompatible surfaces. And the two main ones I want to focus on today include heparin-coated circuits and PMEA, which uses a protective water layer to reduce protein adherence to foreign surfaces. Now, with all this information, though, that leaves a question of how truly biocompatible are these circuits? And that since there haven't been papers regarding the true biocompatibility of these circuits with evidence-based data, my program decided to create a protocol using biomarkers from platelet activation, which would be these that I mentioned earlier, as a way to measure platelet activation during bypass in a laboratory setting. Now, with this idea in mind, there were a few things that we wanted to try and accomplish at the same time. Now, first, we wanted to create a standardized and well-controlled protocol to measure the biomarkers of platelet activation at different time points during bypass in the lab. And the second, we wanted to compare the effects of surface coating. Now, in our case, because we wanted to compare PMEA versus heparin-coated circuits, we looked at Medtronic's Trillium biosurface, which was heparin-based, and then Terumo's X coating for PMEA-based. And then third, we wanted to compare the effects of gaseous microemboli, also known as GMEs, on platelet activation. And now this last one might seem a little odd, but we were lucky enough to have a GME bubble counter that could tell us how much microair could be introduced into the circuit. And then so we figured, why not see if GMEs would also have an effect on platelet activation? So how exactly do we go about this? Essentially, we conducted this to simulate a bypass run in the lab using bovine blood, and then heparinizing it to an ACT level of above 480. And now in terms of the circuits, like I mentioned earlier, we used two types of circuits. We had Trillium, which was the heparin-coated one, and then X coating, which was the PMA-coated one. And we set up those circuits to be exactly the same as one another, with all the components that a normal pump would have in terms of the AV loop side, and we used a centrifugal head for our research. And to normalize everything, we kept the hematocrit around 23 to 27%, and then kept the blood circulating at a rate of 4 liters per minute. We also stayed warm during our bypass run since we were connected to a heater cooler. Now, in terms of our sample collection, we would collect blood samples at 5, 60, and 120 minutes after our so-called bypass run. But here's the twist. Since we're essentially running 2 experiments at one time, this is actually where we stopped in terms of sample collection for comparing the 2 circuit types, and then shifted over to see if there were any effects of GME on platelet activation. So then in that case, on our Medtronic Trillium circuit, we actually had a bubble counter that was attached between the reservoir and the pump head. And after the 180-minute mark, we would take a sample and then introduce GMEs at different RPMs via one of the pump suckers, and then continue taking samples after that until we had a total of a 6-hour pump run. And finally, we had all of our samples, which we isolated plasma from, so we could run our ELISAs and then compare our platelet biomarker concentrations from each run. So just as a visual, this is how we essentially set up both of our Terumo excoding and Medtronic trillium circuits. And I used pump suckers to introduce room air into our Medtronic circuit for the GME portion of our project. So not only can we compare the introduction of GMEs based on different flow rates of pump suckers and vents and reservoir levels, but we could also see if there was an effect on platelet activation. And what we found was that as suction flow rates increased or with a decreased reservoir level, or a combination of both, there was actually a significant increase in GME count. But in terms of biomarkers, we are still in the process of finalizing our data. But so far in our preliminary results, we found that there was a slight increase in PF4, but the difference was so small that it was not considered to be statistically significant. And going back to comparing the biocompatibility of each circuit now, we're still in the process of analyzing all of the data, but just as a sneak peek, we want to look at beta-TG at first. So again, beta-TG is one of the cytokines that are released after platelet adhesion, which is why we decided to use it as a biomarker for platelet activation. And at first here, we used the 5-minute mark as the baseline measurement for each coding, and then found that for the Medtronic trillium circuit, there was actually a slight increase in beta-TG levels, but it decreased back to the baseline levels at the 120-minute mark. Now, on the other hand, Terumo's X coding showed quite a decrease at the 1-hour mark, but it also went back to the 120-minute mark. Now, here's a sneak peek of our data on GP2B3A, which is another platelet marker that facilitates thrombin generation and blocking hemorrhage. And we actually found that since its surface translocation actually increases during platelet activation, it is actually quite a valuable biomarker for us if we wanted to quantify platelet activation and aggregation. But unlike beta-TG, we saw that there was a decrease in platelet activation overall in both circuit coatings. That possibly indicates that both circuit coatings prevented further GP2B3A activation. Now, with any research, though, there's always lots of factors to consider and think about. Now, starting off, how reliable is this study? So my program published this experimental method last year in JECT, establishing a standardized protocol to measure platelet activation. But to ensure its accuracy, we compared our results within each trial run that we had, and what we found was that there was actually a minimum intervariation between each circuit run and at each time point where we measured the platelet activation. So it actually did ensure that this was a very reliable protocol that can be referenced in the future for comparative studies, and that's why we used it for this round of experiments. But on the same note of reliability, we did use ELISA assays, and sometimes those can cause variations in results due to its sensitivity and specificity. And we did our best in terms of ensuring as little variation between our method of drawing samples, running ELISAs, and handling of specimens overall, but it is still something to consider if there were any outliers or questionable results. But another variable that would have been interesting to consider was actually how would these results compare with a completely uncoded circuit? Unfortunately, that is not available from the same vendors for clinical use. But that being said, it does not take away the fact that our original protocol is still reliable and precise, since our results were still duplicable and consistent. But in our recent studies, we did see if we could try and move on to the next step and see if there were any comparative data that could clue us into whether or not there were differences in platelet activation between different circuit coatings. But because we are still in the works of analyzing all of our recent data, we figured that it wouldn't be wise to jump to a conclusion of saying which coating is better at minimizing platelet activation. But it really is interesting to at least see the preliminary data so far and compare and see how our results varied with each biomarker and coating. So from this crash course of our project, there was actually a lot of work put into the final process and publication of this experimental model. And we figured that why not take the next step and see what else we can explore. So like I said in the beginning, this has been in the works of for several years, and then creating and validating the experimental model in the first place was already a really big step that we accomplished. But with anything in perfusion, there's always plenty more to learn. And although I gave a little sneak peek so far of our results from some of the biomarkers, I did also mention some of the other biomarkers such as PF4 and P-selectin, which are results that we're still working on analyzing. So that's going to be something that we're still going to continue looking into. But in terms of GMEs, because of our setup so far, we are able to create a reproducible and established method of comparing the effects of circuit coatings and control GME introduction on platelet activation. And although we still have some other biomarkers to analyze, we think that given the data that we have so far, there is a chance that the GMEs are actually too small to affect platelets, and we might actually need to introduce macro air in order to study its effects on platelets. But that being said, there's always a lot more to learn and many directions that this research can continue on. So hopefully next time this is presented, there's going to be a lot more data to interpret and discuss and share with everyone. But yeah, thank you again to everyone who supported me, including my lovely research team, and thank you for tuning into my crash course.
Lovely presentation, by the way. So I was wondering, did you guys just do the platelet counts, or did you also do the platelet functions when you were doing your research?
Yeah, so we actually just focused on the platelet count mostly just to figure out how it would compare in terms of the intervariations between each of our trial runs. But that would be a really cool next step to look into because you might have all of the platelet counts and such going on, but you don't really know how the function of the platelets are at that point. So that could be something that we could continue looking into in the future as well.
All right, thank you so much. That was so informative. Would you consider this in real life patients?
Yeah, I think that's a really good question because this is essentially impacting our, everything that we do in terms of healthcare and perfusion. But I think there's a lot of factors that could go into, how a patient comes out and their patient outcomes. And with each patient, like every patient is different. So sometimes it would be hard to really make everything unanimous at the same time. So that could be something that we could look into in the future. But I think that would be after we compare all the circuits in the laboratory setting as well.
I have just one last question. When you said that you primed and went on bypass with them, did you have anything besides plasmolate in your prime? Did you have heparin in there or an albumin substance or?
Yeah, so what we had was mostly just heparin and bovine blood and plasmolite. So it was essentially like going on, as you can see here, priming go on, bypass with like just bovine blood. But I think albumin would be really interesting because albumin has been found to, help with the interactions and such. So maybe that could be something that we look into in the future as well.
Really nice talk. Congratulations on the results. I just got a couple of questions. I think temperature has a role to play in platelet activation. So you ran it under normothermic conditions. What about mild hypothermia, or moderate hypothermia? And the other question is, have you thought about the effects of protamine later? If that affects, yeah, of course it does, but between the two tubing, can you comment on both those two questions?
I think looking at it in, for different temperatures would be really cool. I feel like that would be maybe something that we could consider doing as like a start to finish bypass run. Maybe for like even longer than 2 hours because that's essentially, what we do in real life. And, we typically cool the patient to like 34, 32, or even lower sometimes. And, after, not only is the temperature going to affect it, but just the run of the case. And a lot of times we're stuck in those types of cases where, we're on bypass for so long and you end up dropping FFP into the pump. So I think that would be really cool if we can like take that to the next step and see that in the lab setting for future studies. Sorry.
Oh, yeah, of course. So the first question was about what about protamine, I guess, as the next question, like adding protamine into the circuit.
I'm sorry, what? For me? Yeah. Did we give protamine?
No, yeah, so would you consider adding protamine afterwards as well?
Oh, I don't think we gave protamine after. Sorry, I'm sorry, I don't.